Okay, thanks for tuning in for this week's PGY2 and Ambulatory Care webinar series. Our presenter today is Dr. Dana Wright. She's with HSHS Medical Group out of Highland, Illinois, and she'll be presenting on overactive bladder. So with that, I introduce Dr. Wright.
Thank you for the introduction, Chris. So I will be talking about overactive bladder, as this is a common thing that I encounter here at the clinic. So to start off, I really want to talk about how OAB, or overactive bladder, affects our patients. OAB causes a significant burden for patients, including time and effort required to manage symptoms and to find the resources required to obtain treatment. In the United States, chronic urinary incontinence is one of the most common reasons cited for institutionalization of the elderly, and the condition is frequently encountered in the nursing home setting. Carrying out the activities of daily life and engaging in social and occupational activities can be profoundly affected by lack of bladder control and incontinence. Urinary incontinence in particular may have severe psychological and social consequences, resulting in restricted activities and unwillingness to be exposed to environments where access to a bathroom may be difficult. Patients also report negative impact on sexual function and marital satisfaction, and OAB symptoms have been linked to high rates of anxiety and depression, with the majority of patients reporting they have not sought treatment. Bottom line, if a patient reports OAB, it is something to take seriously and dig a little further into. OAB is fairly relevant among our patients. In fact, the prevalence of OAB in females ranges from 9 to 43% and drops to about 7 to 27% in men. Urgency urinary incontinence is consistently more common in women than in men. The condition can affect people of all age groups, but the peak incidence, at least in women, appears to occur around the age of menopause, with a slight decrease in the age group 50 to 60, and then a steadily increasing prevalence after the age of 65. A proportion of OAB cases, about 37 to 39%, remit during a given year, but the majority of patients have symptoms for years, so we are potentially looking at a lifelong treatment and management. So there are various types of incontinence that I just want to briefly go over. So you first have your functional, and really that's just the inability to reach the toilet due to a physical or environmental barriers. And then you have your overflow incontinence, which is your urinary retention, and that sometimes it's due, it is actually often more common in men. And then you have your stress incontinence, which causes increased intra-abdominal pressure from physical activities such as coughing, exercising, jumping, laughing, and that is more commonly caused or found in women. And then what I'm going to be focused on is your urge, or your OAB, which is your inability to delay voiding after sudden severe bladder fullness sensation. You also can have mixed with it, which is a combination of stress and urge incontinence. So going over a little bit more into OAB, so the lower urinary tract consists of the bladder, the urinary sphincter, and the urethra, and surrounding muscle structures, including connective tissue, nerves, and blood vessels. The urinary bladder is a hollow organ composed of smooth muscle and connective tissue. And then the urinary bladder is also known as the detrusor muscle. And then the urinary sphincter is a combination of smooth and striated muscle, and it surrounds the proximal portion of the urethra adjacent to the bladder. So during normal bladder function, you can see that the detrusor muscle is going to relax whenever the bladder is going to start filling. And then the urethral sphincter is going to contract to help prevent urinary leakage. And then whenever the bladder is about halfway full, you get a first sensation to void. But the normal process is that you can inhibit this sensation until the bladder is completely full. And then whenever the bladder is, for the most part, full, the pelvic floor is going to relax and the detrusor muscle is going to contract. So it's going to squeeze that urine out. So then during overactive bladder, the detrusor muscle is going to contract before the bladder is full. So the primary motor input to the detrusor muscle of the bladder is parasympathetic, with acetylcholine being the primary neurotransmitter. Both involuntary and voluntary detrusor contractions are mediated by the activation of postsynaptic muscarinic receptors by acetylcholine. Of the 5 known subtypes of the muscarinic receptors, the majority of bladder smooth muscle cholinergic receptors are of the M2 variety. The ratio of M2 to M3 receptors is approximately 3 to 1, but really what we're going to be focused on is M3 receptors because they are the subtype responsible for both normal emptying contractions as well as involuntary bladder contractions that may result in urinary incontinence. Thus, most pharmacological anti-muscarinic therapy is primarily anti-M3 based. Then you also have your beta-3 receptors, and those are found in the lower urinary tract at the level of the detrusor muscle. Stimulation of these receptors results in smooth muscle relaxation. So clinically, administration of beta-3 agonists is associated with weakening of bladder contractibility and is used clinically to treat overactive bladder and related urge incontinence. Beta receptors are also located on the urethra, but their clinical significance is considered to be negligible. So to prevent incontinence during the bladder filling and storage phase, the urethral sphincter must maintain adequate closure in order to resist the flow of urine from the bladder at all times until voluntary voiding is initiated. So you have your alpha receptors that are located on the striated muscle of the urethra, and stimulation of these receptors is going to result in increased closure pressure. These effects aren't usually enough to treat OAB, but use of these agents may result in unwanted adverse effects such as bladder obstruction and result in poor bladder emptying, such as urinary retention. The bladder and urethra normally operate in unison, and disturbances in the neural regulation at any level, the brain, the spinal cord, or pelvic nerves, often leads to characteristic changes in the lower urinary tract function that may result in overactive bladder. So again, OAB is most often related to detrusor overactivity. So again, we are just going to be focusing on the muscarinic and beta-3 receptors for OAB. The 2014 American Urological Association did publish guidelines on the diagnosis and treatment of overactive bladder in adults, and this is the guideline that we will be focusing on today. So if you were in the previous session with Brad, you do need to retext Dana Wright 288 to 2233. And so really the question that I'm posing to you guys, can you name one of the 4 primary symptoms of OAB? Urge, urgency, Emergency. You guys got a good majority of them. So moving on, so OAB is a clinical diagnosis characterized by the presence of bothersome urinary symptoms consisting of these four classic components. So the first being urgency, which was what you guys all said at the previous question. But urgency is defined as the complaint of a sudden compelling desire to pass urine, which is difficult to defer. Urgency is considered the hallmark symptom. Next, many patients have urinary frequency, which normal frequency consists of voiding every 3 to 4 hours and up to 7 or 8 episodes during waking hours has been considered normal, but this number is highly variable based upon hours of sleep, fluid intake, and comorbid medical conditions. Nocturia is the complaint of interruption of sleep one or more times because of the need to void. Like daytime frequency, nocturia is a multifactorial symptom, which is often due to factors unrelated to OAB, such as excessive nighttime urine production and sleep apnea. Now, the last symptom is urgency urinary incontinence, which is defined as the involuntary leakage of urine associated with a sudden compelling desire to void. And then the degree of bother caused by these symptoms directly affects OAB care seeking, treatment intensity, and satisfaction. If a patient is not significantly bothered by his or her bladder symptoms, then there's less compelling reason to treat the symptoms. Now, if the patient has any alarm symptoms such as pain, blood in their urine, abnormal digital rectal examination, recurrent UTIs, or a post-void visual of a greater than 200 milliliters, then a referral to a specialist is warranted because there might be an underlying issue going on. So with that being said, comorbid conditions and environmental factors should be completely ruled out as these may directly impact bladder function. Specifically, bladder function is related to the amount and type of fluid intake. Excessive fluid intake can produce voiding patterns that may mimic OAB symptoms. And for this, you really need to ask about their fluid intake habits, including how much fluid and what type of fluid, for example, with or without caffeine, how many times they void each day, and how many times they void at night. Patients who can't provide accurate intake and voiding information should really fill out a fluid or bladder diary. OAB symptoms may occur only at night, causing a single symptom of nocturia, so it's important to rule out sleep disturbances, vascular and or cardiac disease, and other medical conditions which are often associated with nocturnal polyuria. Now, frequency that is a result of polydipsia and resulting in polyuria may mimic OAB, and the two can only be distinguished with the use of frequency volume charts. So in polydipsia, urinary frequency occurs with normal or large volume voids, and the intake is volume matched. Other conditions, such as UTIs, can share the symptoms of urinary frequency and urgency, whereas your atrophic vaginitis can be an underlying cause to incontinence. So, of course, make sure the symptoms are not related to your neurological diseases, mobility deficits, pelvic cancer, or uncontrolled diabetes. Those are all other conditions to rule out. So the diapers mnemonic is a neat and fun way to remember what to rule out before making a diagnosis, and it's going to include the delirium, dementia, infections such as your UTI, the atrophic vaginitis, your pharmacological agents like your diuretics, your psychological disorders such as depression, endocrine or excessive urine output, your reduced or restricted mobility, and your reversible urinary retention and stool impact. A quiz for you guys. Which medication worsens OAB symptoms? we got one result. I'll wait for a couple more. Okay, so let's see what you guys said. Okay, so everyone said all of the above. Unfortunately, that's not right. So it's actually just D, A and B. And we'll go over this in a minute, but it's actually dopamine agonists that worsen OAB symptoms. So let's move on. So again, I really like this diagram because you have your receptors on the right, and then the drugs or agents that can worsen. So you, again, have your calcium channel blockers, your opioids, muscle relaxants, antidepressants, antipsychotics, dopamine agonists, not antagonists, anticholinergics, antihistamines, and then your alpha blockers. And I really like this chart too. This was taken from US Pharmacists, but it breaks it down by your different types of UI and what causes a worsening of those symptoms. So again, you can see for OAB, you have the alcohol, caffeine, diuretics, and lithium as well. So prior to initiating treatment, the clinician should provide patient education regarding normal and abnormal bladder function, including bleeding frequency and toilet behavior. Explaining what is normal can help the patient understand how their condition diverges from normal and gives them a comparator or goal for judging their own progress in treatment. Expectations are important because they affect motivation and adherence, and they can influence the patient's interpretation of treatment effects and satisfaction with outcomes. Most OAB treatments can improve the patient's symptoms but do not completely eliminate them, and that's important to tell your patient. Patients should have a clear understanding of the risk and burdens of particular treatments, and patients may decide that going from 5 incontinent episodes per day to 3 episodes per day is not worthwhile given the long list of adverse events associated with that treatment. So it is crucial that the patient understands that the treatment progress and outcomes will depend on their active participation and persistence over time. And that process is usually gradual, and change can be irregular. You can have good days and bad days, and long-term change in symptoms really depends on their long-term change in behavior. So the guidelines outline your first, second, and third line treatment options. Your first line is going to be your behavioral therapies. This is going to be offered to everyone because it has no risk. Your second line is going to be your pharmacological agents. They're non-invasive. The adverse drug effects are readily reversible, and that's your antimuscarinics and your beta-3 agonists. And then your third line is going to be more invasive treatments. And then treatment failure is defined as intolerable ABRs or your desired change is not met. Okay, so another question for you guys. What behavioral therapies do you recommend for a patient with OAB? So what type of first-line treatments are you going to give? Yep, Kegels. Kegels. I actually don't know how you spell. I think the K is right. Yep, drinking less water, that definitely can be one. Really looking at that bladder diary. Timed voiding, that is crucial. All right, we'll move on. So most effective behavioral treatment programs include multiple components and are really individualized to the unique needs of the patient and living situation. So the two fundamental approaches to behavioral treatment for OAB, and one is going to focus on bladder training, which modifies the bladder function by changing your voiding habits and delayed your voiding. And the other approach, behavioral training, focuses on the bladder outlet and includes pelvic floor muscle training to improve strength and control, and also provides techniques for urge suppression. So those pelvic floor muscle training is your Kegel exercises. And then self-monitoring is so important, and it can be completed by, again, using that bladder diary and tracking things as your schedule voiding, your delayed voiding, your double voiding, your urge control techniques such as distraction, and your fluid management and caffeine reduction. Although most patients do not experience complete symptom relief with behavioral intervention, typical mean improvements range from 50 to 80% in frequency of incontinence. So that's pretty significant. Another management strategy is weight loss, and on average, a 6-month weight loss intervention that resulted in 8% weight loss in obese women reduced overall incontinence episodes by 47% per week. So again, first-line treatment should be initiated in all patients and should be continued even if they are not put on a medication. So the first medication I would like to talk about is mirabegron. It activates the beta-3 adrenergic receptors in the bladder, resulting in relaxation of the detrusor smooth muscle during the urine storage phase, thus increasing the bladder capacity. At usual doses, mirabegron is believed to display selectivity for the beta-3 receptor subtype compared to its affinity for the beta-1 and 2 subtypes. Your initial dose is going to be 25 milligrams once daily, and efficacy is observed within 8 weeks. Now, you may increase to 50 milligrams once daily based on individual patient efficacy and tolerability. You can see the renal dosing on the slide, and adverse drug reactions do include hypertension, tachycardia, headache, dizziness. You got your dry mouth and your constipation. And then you really want to use with caution in patients with history of QT interval prolongation or those receiving medications known to prolong the QT. In one study, supratherapeutic doses did cause a prolonged QTC in females, but not in males. But in general, mirabegron at the recommended dose has a low risk of QT interval prolongation unless you keep going up to higher. So then your antimuscarinic agents, you have darphenocin, fesoterodine, oxybutynin, sulfenacin, tolterodine, and trospium. So there is quite a few. Now, clinicians should be cautious when prescribing these agents. They need to ensure that they're not being used in patients with narrow angle glaucoma unless approved by the treating ophthalmologist, and really should use antimuscarinics with extreme caution in patients with impaired gastric emptying or a history of urinary retention. Anticholinergic agents may enhance the ulcerogenic effect of potassium chloride, so patients should avoid using any solid oral dosage forms of potassium. Also, be cautious about the current use of other medications with anticholinergic activity, as they may increase the side effects. And so these medications include your TCAs, those used in the treatment of Parkinson's and Alzheimer's, such as benzotrophine, galantamine, donepezil, and rivastigmine. And certain anti-nausea medications and those with atropine-like properties, such as ipratropium, may also increase side effects. And lastly, in frail patients, defined as patients with mobility deficits and cognitive deficits, the use of OAB medications may have a lower therapeutic index and a higher adverse drug event profile. So clinicians should really begin with the lowest possible dose and increase doses slowly while carefully assessing for the balance between symptom control and adverse effects. So although these medications reduce symptoms, they can commonly have the non-life-threatening side effects such as your dry mouth, constipation, dry or itchy eyes, blurred vision, UTI, urinary retention, and impaired cognitive function. And more rarely, life-threatening side effects like the arrhythmias have been reported. But one of the main limitations is that the majority of patients discontinue therapy after a few weeks or months, but the guidelines specifically states that clinicians should manage constipation and dry mouth before abandoning effective antimuscarinic therapy. There are multiple methods to help alleviate these unwanted side effects. For example, even before initiating therapy, patients should be educated about the possible side effects on bowel function and the roles of adequate dietary fiber and fluid intake, regular exercise, and normal bowel habits. And then preparing for dry mouth might include advice on oral lubricants, avoiding mouthwashes with alcohol, taking small sips of water, sucking on sugar-free hard candies, and even chewing sugar-free gum. Also, if an immediate release and an extended release formulation are available, then the ER formulation should preferably be prescribed over the IR formulations because of the lower rates of dry mouth. And then if a patient does experience inadequate symptom control or unacceptable adverse drug events with one antimuscarinic medication, then a dose modification or a different antimuscarinic medication or even a beta-3 agonist may be tried. So pharmacological therapies have no compelling evidence for different efficacy across medications, but there was different adverse event profiles for dry mouth and constipation. So there is some suggestion that the oxybutynin is the worst offender for dry mouth, while darfenicin is the worst offender for constipation. Yet data has shown that the newer agents, such as darfenicin, may also be less likely to produce cognitive defects in the elderly patients than the older agents. And then keep in mind that transdermal oxybutynin, either your patch or your gel, is effective in reducing your OAB symptoms with dry mouth rates that appear to be less than the rates for the oral oxybutynin ER and oral oxybutynin IR. Interestingly, the oxybutynin IR has dry mouth rates of 68%, and the oxybutynin ER has dry mouth rates of 40%. So again, that's why it's important to try switching a patient to the ER formulation. But ultimately, it's going to come down to trial and error. Some patients who had prior unsatisfactory symptom control and or unacceptable adverse events with tolterodine or oxybutynin reported better efficacy with festofenadine or darfenicin. So keep in mind that it may take up to 12 weeks for full efficacy and a little bit of playing around with the medications. So there is some data, though, with the beta-3 agonist to show that it has similar efficacy but lower side effects. So you can see, like with dry mouth, at the 100 milligram dose, it was reported at 2.2%, where it was reported at 9.5% for the ER version of tolterodine. And for constipation, it was 1.6 versus 2.0%. So that part was similar. But then for hypertension, it was reported at 3.4% versus 6.1%. So overall, the data, again, indicates it's similar in efficacy, but with lower rates of dry mouth and constipation. So if a patient is complaining of intolerable side effects, a beta-3 agonist could be the way to go. So I want to go over really quickly all of the agents, and I did get this chart from the pharmacist letter. It was published in 2012, so I did have to make a few changes on the generics availability. But so Enablex, it is M3 selective. You can see the dose 7.5 once daily and then bump it up to 15. It is generic, and then I really like this chart again because it shows the rates of the adverse events. So dry mouth about 20% and 35%, and constipation between 15 and 21%. Next, you have your Toviaz. It is nonspecific for M3 versus M1, and you have your 4 milligram and your 8 milligram doses. It is not generic though, however. Your Vesicare, it is slightly more M3 than M1 selective. You have your initial 5 milligram dose and your max dose of 10 milligram. Now this is generic, and dry mouth rates are about 10.9 and 27.6%. So it does increase quite a bit whenever you go up to that max dose. And then you have your Detrol, your long-acting and your short-acting. So this is non-specific for your M3 versus your M1, just like your Toviaz. And then you have your initial and max doses, and both of these are generic. And again, you can see the dry mouth rate for the IR version is 35%, where the ER version is 23%. And then you have your Sanctura. That is non-specific for M3 versus M1. And your dosing is going to be 20 or 60 initially, and then you can you stay at that same, well, you start off, yeah, you stay at that same dose. Sorry, I was reading the chart wrong. But the Sanctura, just immediate release is generic, and the XR version is not generic right now. And then lastly, you have your Mybertique, which is your beta-3 agonist, and we already went over this, but I thought I would include it in the chart. And then finally, you have all of your oxybutynin agents. I won't go over all of this, but do know that the oxybutynin patch is approved over the counter for women over the age of 18 years. Again, the patch and the gel are going to have less side effects than your oral oxybutynin forms. Okay, and then really quick, I want to go over this chart too, because it has your renal adjustments and your hepatic adjustments, and also shows the breakdown of how each agent is metabolized. So Enablex is going to be your CYP3A4 metabolite with no renal adjustments, but you do have your hepatic adjustments. Toviaz, it is going to be metabolized by your esterases and then by your CYP3A4. You do have to renally adjust, but no hepatic dosing. Your Mybertique is metabolized again by your CYP3A4 and CYP2D6. Renal dosing is on the slide, and then hepatic dosing as well. Your oxybutynin is metabolized by your CYP3A4. I'm sure you're seeing a trend here, but no renal adjustment needed or hepatic adjustment needed. Your Vesicare needs both renal and hepatic adjustment. Your Detrol, again, is going to be your CYP2D6 as a major and your CYP3A4 as a minor, so that is a little bit different. And then your Sanctura, again, it's going to have your esterase hydrolysis and conjugation with your renal adjustment, and your hepatic you should use with caution. And lastly, talking about your third-line treatment. So in situations where the medical management of burdensome OAB is not feasible, or it's not effective, or it's not recommended in your patient, if they have severe cognitive deficits, then your other management options may need to be considered. So clinicians can offer your Botox, and make sure to, before you offer this, of course, make sure that they have been refractory to first and second line treatments. And the patient must be able and willing to return for frequent post-void residual evaluations, and even be willing to perform self-catheterizations if they undergo the Botox. And then as a last resort, an indwelling catheter may be considered when urinary incontinence has resulted in the development and progression of ulcers. But management with diapering and absorbent garments is always preferred over your indwelling catheters because of the high risk of catheter-associated infections. Also, intermittent catheterization may be an option when co-occurring incomplete bladder emptying is present, leading to overflow incontinence. But I do want to point out that OAB is not a disease, but rather it is a symptom complex that is generally not life-threatening. Therefore, per expert opinion, no treatment is always an acceptable choice and may be made by some patients and caregivers. So questions that should be asked include, is the patient's quality of life going to improve with treatment? In patients who cannot perceive symptom improvements or an increase in quality of life, treatment may not be appropriate and may be potentially unsafe, especially in the very elderly or demented patient. Also, to treat incontinence, optimally the patient must have a desire to be continent or have a desire for symptom improvement. In patients with cognitive deficits, this desire may not be present, and family and or caregivers may have difficulty understanding that simply giving a medication will not correct the problem. And in certain patients for whom hygiene and skin breakdown are major concerns, treatment may be considered regardless of the patient's perceptions due to the significant health risk. And then if the patient is at an increased fall risk, untreated incontinence can result in a fall when a patient has compromised mobility, attempts to move very quickly. So really the clinician needs to look at all of the factors, all of the adverse drug events, and make an educated decision based on the overall picture. And with that, that is the end of my presentation, and I will take any questions that you guys may have. Oh. So Brad, is there data for Kegel exercises in both males and females? That I don't know. I know really it's stressed in females because those Kegel exercises are going to be really good for that stress incontinence, which is going to be more common in your females rather than your males.
So Dana, what do you see the providers steering towards at your clinic for overactive bladder?
I see everything. I see a lot of Mybertique whenever they can get it approved because it's not generic right now, but it is a good choice because of potentially the less side effects. But I see a lot of Vesicare as well. And really, I mean, your muscarinic agents are all going to be equally effective, so I think it's just comes down to insurance. I see some Tovias, not so much, but I do see a little bit of that.
Do you all ever refer women to the Women's Health physical therapist for pelvic floor training, or is that more for people that have had problems with the mesh or the sleeves?
I haven't really seen any of that. I kind of think more common is to just put on a medication before doing behavioral therapies like the pelvic floor training, even though that's what you should do.
Our problem at our clinic is everybody gets referred out to urology, and I'm not sure that's necessarily a reasonable way to tackle this firsthand. I mean, I don't know.
No, I don't think unless they're having like those alarm symptoms, or unless they're having more of those neurological deficits that's causing the OAB, this is manageable by a primary care doc. I mean, I don't want to say it's simple, but other than managing the adverse drug effects, there's really not a whole lot to it. And really, I think it's so important to keep a bladder diary, because that's whenever you can really know if the treatment is helping or not.
Is this something we should think about adding to our standing order set or collaborative practice agreement based on your newfound expertise?
Oh, for sure, because this takes a lot of time to manage, even though it's, I would say, more easier to manage, but it is time consuming for the physicians because a lot goes into it, especially if you're looking over those diaries. And it affects the patient's quality of life so much that I really do think potentially it could be added. Pharmacists could easily manage this, I think.
Okay. And something you might be interested in, or I guess
Yeah,
you could.
I would be.
Okay. All righty. Any other questions for Dr. Wright?
Also, if you guys have any topics that you want me to talk about next week or whenever, just let me know.
I'm working hard to try to find some colleagues to help take the load off, but I've found these very enjoyable and are certainly informative. And I'm certainly not the expert in any of these areas, so
I'm trying to choose topics that aren't so common, so maybe people can get a good refresher. But yeah, any ideas, just let me know.
okie dokie. How about one on anxiety associated with upcoming nuptials?
Oh, yeah, I would be good about that. I could tell you all about it.
All right. Well, hey, thanks again, Dana, and I'm going to